Good morning, everyone. My name is Megan King, and I am one of the public health educators at the Washington Poison Center. We are in the second week of our overdose prevention, harm reduction, and treatment series. Over the last week, we have welcomed a bunch of our own Poison Center staff members, as well as some of our partners from across the state of Washington, to engage in conversation around overdose, around stigma, and around many of the complex issues that are facing our communities. So today is a particularly special day during our series. August 31st is International Overdose Awareness Day. And this day is when people from all over the world come together to talk about overdose, to remember and to grieve those who have died, and really to stimulate discussion around how we can understand overdose and how we can take action to prevent it. So I am so grateful for the guest speakers that we have today with us to help celebrate Overdose Awareness Day, as well as to help us round out the live streams that we have during this series. So I would like to welcome Sean, who is the Overdose Education and Naloxone Distribution Consultant with the Washington State Department of Health. We have Mitch, who is the Prevention and Outreach Program Specialist at Hepatitis Education Project. And we have Kimberly, who is a care coordinator at Hepatitis Education Project. So thank you all for being here today.
Thank you.
Before I turn it over to Sean to start us out, I have just one housekeeping item. We would love to bring you into the conversation during this session. So please post any of your questions, post your comments in the comment section on Facebook or YouTube, whichever platform you are watching on. So that is all I have. I will turn it over to Sean and we'll get started.
Sounds good. Thanks, Megan. So good morning, everyone. We're going to talk a little bit today about opioids, what they do, what they are. We'll talk about fentanyl, and we'll look at some laws and regulations around naloxone and overdose response here in Washington State. So opioids, what are they? Well, at their heart, they're a painkiller. Okay, they relieve physical pain, and in a lot of people, they relieve psychological and emotional pain as well. They are really good at what they do. Okay, there's a reason why these are prescribed so often. They're very good at taking away pain. They're also considered a central nervous system depressant, meaning they slow down your breathing. When you ingest an opioid, it winds up attaching to the brain receptor called the mu receptor. That's M-U, not M-O like a cow, but M-U. And that's the receptor that also tells your body to breathe. So opioids can be either opiates or opioids. An opiate is something where the active ingredient is derived, it's found in nature. Okay, so this would include substances like morphine and codeine. Heroin would be considered semi-synthetic because it contains processed morphine. Synthetic opiates, or opioids, these are ones where the active ingredient is created by a human. So these would be substances like fentanyl, Dilaudid, methadone. Substances like oxycodone or oxycontin would be semi-synthetic because it's processed from theobromine, which is an opium alkaloid. Can you advance the slide, please? Issues advancing the slide.
Sean, you might just need to stop sharing and reshare. We can try that.
Okay. It's coming up. Don't worry, folks.
No worries. I think everyone
You want to get everything
understands.
just exactly perfect, you know.
Everyone understands tech issues these days.
Okay, so there we go. I don't know why it's not allowing me to do this anymore.
Is it not allowing you to share your screen?
How about this? We'll do this. Okay. Can you see that slide?
I think you need to hit share your screen again.
I'm doing it. It's not.
All right, I think let's switch over to our folks from HEP.
Yeah.
Yeah, and we'll let them go through their presentation.
Thanks.
Oh, wait, actually, yeah. Let's have them go through their presentation and we'll switch back to you, Sean. Okay.
Thank you.
All right, thanks for bearing with us, folks. Hang on just a second. Let me switch over.
All right, let me unmute myself. Okay, 1 second. Okay, so we are going to be presenting, so Sean was going to give sort of a higher level state perspective on opioids and fentanyl and trends in Washington state. And Mitch and I are going to talk more about how our services here at HEP impact drug user health. So we're switching it up a little bit. You're kind of going to get the micro view before you get the macro view, but that'll totally be fine. I'm going to go ahead and put this in presenter mode. And yeah, so let me introduce ourselves. Like Megan said earlier, I'm Kimberly Tabor. I'm a care coordinator at Hepatitis Education Project, or HEP as we call it. And Mitch.
There we go. Hello, I'm Mitch. I'm the program and the prevention outreach program specialist at HEP.
And so, yeah, again, our focus is going to be talking about the services that we have here at HEP and how those impact drug user health safety. So I'll start with a quick introduction of HEP. Our overarching goal is to improve the health of underserved communities disproportionately impacted by viral hepatitis. So that means hepatitis A, B, and C specifically. And we have a fixed site location on Jefferson and 16th Street in the middle of the International District and the Central District, right in between them in Seattle. And at our fixed site, we offer clinical services, we have a prevention and outreach team, and we also have case management services. And then I also want to mention that we have an amazing correctional health program, and we have an advocacy and policy program that's based in DC. But today we're mostly going to be talking about the services that we have here at our fixed site and how they impact drug user health. So I'm going to turn it over to Mitch to talk about one of those services. And let's see, did that advance to the next slide?
Sure. So Hepatitis Education Project, we do run a Syringe Service Program. It's the furthest one south in Seattle. There are other orgs that do deliver to outside of Seattle, but our static SSP is here at our 1621 Jackson Street location. As you can see, we offer quite a bit of stuff. Our main focus, of course, is getting unused needles into the hands of people who do inject drugs. New needles are important. According to the CDC, most new cases, about 75% of the hepatitis C virus, are transmitted through needle sharing. We also encourage clients to pick up some works that do go with using, such as cottons, ties, cottons, ties, foils, in order to reduce the risk of contracting HCV or any other bloodborne pathogens. We also provide meth pipes. Inhalation is a form of harm reduction that can help reduce chances of overdose. It's definitely not foolproof, but that option is there. We also, during this time, we have case management through the STEP program, through country doctor, running downs, and sound clinicians come. So if folks do want to start, do a med start with Suboxone or buprenorphine, they can access those services here as well. So we also do distribute Narcan as well as Naloxone to our participants. They can grab 2 or 3. Lately, we've been hearing that just through SSP and during outreach, we do go to encampments and have conversations about Naloxone, Narcan, as well as the importance of fresh needles, clean syringes. And what we've been hearing is that in order to revive someone, or it's been going around a lot, that people are needing 2 or 3 doses of Naloxone. There's 2 doses in each of these vials. One on the left is the nasal Narcan. One on the right is the intramuscular Narcan. So people are saying it takes maybe 2 nasal or 1 injectable or 2 injectables and 1 nasal. But I think people are trying to be as cautious as they can. But unfortunately, and you can see the data through King County, there's just been a rise in overdoses. So we're really trying to get people to understand the importance of carrying Narcan or Naloxone while using with a friend, and just if you're able to test the substance you're using. We do supply fentanyl testing strips as well. We encourage clients to grab a few of those and test their product if they're able.
So yeah, the Syringe Service Program is one of the services that we offer at HEP, but as Mitch mentioned, we really care about co-locating as many services here as possible, so that if a client comes for the Syringe Service Program, or maybe they come for Hep C testing or whatever it might be, that they find other services and resources here that may also be applicable to their health. And so because of that, we really try to focus on linkages to care. We have a lot of partnerships with other agencies in the community, and I'm going to talk about a few of them. But first, when somebody comes to Hepatitis Education Project, we offer Hep B and C testing, as well as Hep A and B vaccines. And if somebody does come back with a positive Hep C test, they are able to enroll in our care coordination program, which is a case management program. We help people from diagnosis through treatment to cure, whether that's navigating insurance, whether it's finding a provider that will treat Hep C, or even oftentimes it's just building a rapport and relationship with people so that when they are ready to be treated, even if now isn't exactly the time for them, they know what their options are, and they know that we're here and ready to help when they are ready for treatment. So that's a great option for people. And then also about Hep C recently, very exciting, we have a partnership with University of Washington and Kelly Ross Pharmacy, where we're participating in a study to explore a community pharmacist model. And what that means is that every Thursday we have a community pharmacist here at HEP, and she is able to prescribe Hep C medications to people. So instead of somebody coming in and being tested, finding out that they're Hep C positive, and then having to be referred out to someone else, which is a huge barrier for our clients, now they can get it all done here at HEP. So our community pharmacist does the blood work, gives the medications, follow-up, SBR12, all of that can be done here in-house, and that is a really huge opportunity for us and our clients to get rid of a really big barrier for treatment that a lot of our clients face. We also have the Seattle STEP Clinic. It is our clinic for medication for opioid use disorder, and that is made possible through partnerships with Country Doctor Community Clinic, as well as Sound, who provides some mental health services for folks here. So again, if somebody comes in for a syringe exchange, they can get help with Hep C treatment. They can get help with medication for opioid use disorder medications if they're interested. And if they're not interested, we still let them know that the services are there. And then again, when they're ready, they know their options. We also have a lot of other partnerships with community members and agencies, so that when our clients have a need that we're not able to meet here at HEP, we have a great network of providers that we can connect folks with and do warm handoffs so that they feel comfortable getting services that are stigma-free and that will meet them where they're at and have a harm reduction approach. So some of those community partners are like the People's Harm Reduction Alliance. We do a lot of outreach and testing at different community agencies. So there's a lot happening at HEP. And lots of opportunities for people who use drugs to come and have an impact on their health. So I think next what we're going to do is a short demo of the intramuscular naloxone and the nasal Narcan. I'm going to exit out of this full screen so I can see where we're sharing. Okay, perfect. And Mitch, do you want to go first with the intramuscular?
Sure. So I am naloxone, or intramuscular naloxone is an injection of naloxone to prevent opioid overdose. Some things that can cause an overdose is, like I've mentioned before, unknown strength of what folks are getting with street drugs, using pain meds more often, and of course mixing opioids with alcohol, speed, or anything like that. So if you suspect someone is having an overdose, we of course suggest to try and wake them up. Someone who's overdosing can look like they're just asleep. Some people might be really just out of it. So the good old sternum rub across the chest is really uncomfortable. Try that a few times. Warn them. Say, "Hey, I think you're overdosing. I'm going to give you a dose of Narcan." Some people like to call 911 first. Some people like to do the injection or the nasal spray before calling 911. But if you suspect that someone is overdosing and you do have naloxone with you, here's what you should do. So comes in an amber bag. Oops, there we go. You see this little dose. This is one dose of naloxone. I'm going to take it out, but naloxone is very light sensitive, which is why it's in an amber bag. So you don't want it just to be hanging out, on your desk like a bowl of candy. Come by, get it. So there she is. What you'll do is remove the orange cap. This is actual naloxone, so I'm not going to do that. I don't want to waste a dose. So you remove the cap. Then you would get your syringe. This is a 3cc Kessin syringe needle. Sorry, my camera is a little off. So 1, 2, 3. So what you would do is you would take this vial, flip it over, uncap your syringe, insert the syringe into the vial, and if you insert it all the way, you're just going to be drawing air out. But insert just a little bit. You can draw most of it out, and then if anyone is are kind of familiar with this, but you will have to push the plunger a little bit to get air bubbles out, kind of knock it around. And you can insert this injection either in the thigh, the deltoid, the butt, back of leg, anywhere where there's quite a bit of muscle. You just push that plunger down and then wait a few minutes, 3 minutes. It'll be a really long 3 minutes. Continue to just monitor them. Make sure they're breathing. If they're not breathing, definitely after the naloxone, do give rescue breaths if you feel comfortable, or compressions. And at that point, if a person isn't waking up, you can do a second dose of the IM or nasal. Repeat steps 1 through 5. Try to wake them up. Let them know that you are going to give them naloxone or Narcan. Continue those compressions or breaths, and at that point, call 911. Just say that someone isn't breathing. Sometimes, if you mention an overdose, the police will come, or that can be an escalated response. So just say, hey, I have someone here who's not breathing, and wait till 911 arrives. And that's for IM. So
yeah. So I have the nasal Narcan. It's really similar. It's basically the same process that Mitch just said. You're going to check for responsiveness. You're going to call emergency services, and then you're going to administer the medication. So nasal Narcan, it looks like this. This is the box that it comes in. There's 2 doses per box. And they're individually wrapped inside, but so you just unwrap it. This is what it looks like. You don't have to take any caps off or activate it in any way. You just hold it like this with your thumb on the plunger, and then you insert it into the person's nostril and just press the plunger. Similarly to what Mitch said, wait 2 to 3 minutes before giving a second dose. Time can be really hard to keep track of when you're responding in an emergency. So some people suggest setting a timer if you have your phone nearby. Sometimes 30 seconds feels like 5 minutes in that type of situation, but it is really important to wait those 2 to 3 minutes to let the medication have time to do what it does. And then do rescue breaths for those 2 to 3 minutes. It's really important to keep getting oxygen to the brain if someone's breathing is really shallow or non-existent. And when you give the second dose, if they don't come to, you can give another dose and do it in the other nostril. And you can just keep repeating this process until either they come to or emergency services arrives. And then I would say too, when someone does come to and you're with them, just explaining to them what has happened. They might be really disoriented. They probably won't remember that they've overdosed, and speaking in short, clear sentences, saying you overdosed, I gave you Narcan, emergency services are on their way, and give them some space. Again, they're going to be really disoriented. They might not feel very good physically as well if they're going through precipitated withdrawal. So just give them space, be gentle, and try to explain to them what has happened, because they really might not know. And yeah, I think that's it. If you have any questions, I think we're going to hold them to the end, but happy to talk more about our services here at HEP, any overdose response questions, how to use Narcan or Naloxone, any of that, we'd be happy to answer questions. But I think Sean is ready with his presentation, so we'll pass it over.
Great. Thank you so much, Kimberly and Mitch, for going through all of that. I'm going to get Sean pulled back up as well as his slides. Fingers crossed tech is going to work this time. So hang on just a second. Let me get these shared for you all. And as a reminder, please put any questions that you have for Kimberly, Mitch, and Sean in the comment section on Facebook or YouTube, and we will be sure to get to those questions at the end of this.
There we go. All right, looks good. Thanks, Megan, and thank you, Mitch and Kimberly, for your presentation and for jumping in under super short notice. Really appreciate you. And I would just like to quickly stress one point that that Kimberly made regarding administering the second dose of naloxone, or third or fourth. Use a timer whenever possible, because she's absolutely right. Those 3 minutes can seem like a lifetime, and you don't want to give too much naloxone too fast. So where we left off was with opioids, which were the synthetic version of opiates, where the active ingredient is created by a human. Now, these drugs, again, they're prescribed for pain primarily. People take them recreationally, though, because they make them feel good. You know, again, they're really good at taking away physical pain, emotional and psychological pain. Folks who have experienced trauma in the past will sometimes take opioids to feel better. Now, we're not here to judge, why people take them, or the reasons behind usage. It's simply, why folks are taking them. The concern around taking opioids, though, is that if you take them for a length of time, be it a couple days, a couple weeks, or even longer, your body is going to develop a physical need for them, because your body already produces its own opioid called dopamine, which is a neurotransmitter that triggers euphoria. Now, if you introduce an outside source of opioids to your system, be it in the form of Oxycontin or heroin, well, your body is just going to take a vacation and produce less dopamine. And if that outside source happens to get cut off for some reason, say you can't find your heroin dealer that morning, or your doctor refuses to write you another prescription for Percocets, well, your body can't automatically produce enough dopamine to get you back in level immediately. It's going to take some time. And that, some people refer to that length of time as kicking, or being in withdrawal, being dope sick. And the length of time it takes to get better is going to vary, depends on how much of an opioid you have been taking, the way you've been taking it, like the route of administration, like were you injecting it or smoking it, snorting it. It'll depend on the purity of the opioid that you've been taking. You'll get better eventually, but it's going to take a little bit of time. Next slide, please. Next slide, Megan, please. Thank you. But remember, though, at the end of the day, be it opioids or opiates, they're going to do the same thing to your body. Both attach to the same brain receptor, that mu receptor that I talked about earlier. Can you go back one, please? Thank you. They both trigger euphoria. They can cause nausea in some folks. They cause drowsiness in some people. Again, they're really good at relieving physical and emotional pain. They slow down your breathing because, again, opioids attach to that brain receptor that tells your body to breathe. They can cause constipation in some people, slowed reaction time, and many folks will experience what's known as a nod. And that nod, the best way to describe it is a simple 10 or 15-second nap where you simply nod off and then wake back up. Some people can nod off standing up. Next slide, please. Okay, so fentanyl. I'm sure many of you have heard or read or seen stories about fentanyl in your social media feeds and your buzz feeds, your news feeds, and whatnot. Why are we concerned about it? Well, let's take a little, do a brief history of it, and then we'll talk about, the main reason why we're concerned. Fentanyl has been around for decades. It was created back in the 60s, and it was designed, the illicit version at least. This is the version that you'll find in hospitals and medical facilities. The illicit version was designed to address breakthrough pain. This is pain that folks experience when they're going through circumstances like end-stage cancer pain, or if they're going through HIV wasting syndrome, pain associated with that. These people are already taking numerous opioid-based pain medications throughout the day and night, yet they still manage to experience pain that breaks through the medications they're already taking. And so fentanyl was designed to address this. Fentanyl is a synthetic opioid, meaning that the active ingredient is created by a human. It comes on very fast. The effects, depending on the route of administration, be it if you took it via injection, it could be felt in as little as 3 to 4 minutes. If you take it via a transdermal patch, meaning the patch that you put on your upper outer arm, those effects last for a couple days, around 72 hours. It's designed to be time released. It's very potent, meaning it's measured in micrograms, so a millionth of a gram. So it only takes a little bit to feel the effects. And it's also short lasting. The effects go away rather quickly. Depending on how much you took, the effects might go away anywhere from 25 to 45 minutes. It can be administered in a hospital or clinic setting via patch, lozenge, which is like a lollipop that you just suck on, a sublingual spray, meaning a spray that you spray underneath your tongue, and also an injection. Now, the illicit version is the kind that we're finding on the street, the kind that's being mixed into the street level drug supply. People take it for, whatever the user wants it for, right? Take it recreationally to feel better, to stave off withdrawal symptoms, whatever they like. It's also synthetic, meaning the active ingredient is created by a human. And again, we're finding this in many of the drugs being sold on the street nowadays. On the West Coast here, it took a little bit longer for it to really to find a footing in the drug supply. It's been pretty prevalent on the East Coast and up in British Columbia, up in Canada for a while, but we've really over the past year and a half been finding it here. We're finding it in the heroin, sometimes in the methamphetamine supply and the cocaine supply. Primarily, though, we're finding it in these pressed pills. They're blue pills called M30s. They're marketed on the street as being Percocets, which is another opioid-based pain medication. However, it's not Percocet. These pills actually contain fentanyl. The amount, we just don't know. But for the most part, they will contain fentanyl. Again, the purity and the origin is unknown, so we don't know how much is in these pills or the purity of it. And with the pills, it's especially concerning because fentanyl does not mix in evenly. Okay, chocolate chips. So I want you to picture a chocolate chip cookie. Think of the cookie part as the cutting agent and the chocolate chips as the fentanyl. And when you share a cookie with someone, your half might not have very many chips, their half might have a bunch. Well, it's the same way with these pills. You might share a pill with someone, your half might have very little to no fentanyl, their half might have a whole bunch, So again, it's a subject of concern. Next slide, please. And click on this again for me, please, Megan. Now, I want you to picture a packet of sugar. And this is why we're concerned about fentanyl, primarily. Picture a packet of sugar. We're going to do some math here, all right? And every one of us has probably seen one of these packets of sugar before. Maybe not that brand, that C&H brand, but we've all held one probably. A packet of sugar weighs roughly 3 grams, okay? Now, in a hospital setting, where the lowest dosage of fentanyl that you'll receive will be 100 micrograms. Now, 100 micrograms most likely will not cause an overdose. You'll feel the effects, but it most likely will not cause an overdose. Click the next slide, please, 3 times. Out of that packet of sugar, you can make 30,000 of those 100 microgram doses. All right, 30,000. Now, again, 100 microgram dose of fentanyl, probably not enough to cause an overdose. However, a 400 or 500 microgram dose very well could. And you can imagine how difficult it is to measure out a single dose, right? And so this, in a nutshell, is why we're seeing so many folks overdose. They simply cannot measure out a safe dose of this stuff. It would be great if they could, but it's simply not the case right now. It's I don't want to call anything impossible, but it's pretty close. Next slide, please. So trends that we're seeing right now in Washington, and some of these could be said for across the country. Again, the biggest one has been the rise in illicit fentanyl. We're seeing it all across the street level drug supply, primarily in those counterfeit pills, but again, it's showing up in things that can be unexpected, primarily in methamphetamine. The half-life of fentanyl requires more use throughout the day and night to stave off withdrawal symptoms. Half-life means the length of time it takes for half of the substance to be processed through your system. Now, another consequence of fentanyl is that we're seeing people who maybe up to a year or a year and a half ago, they were primarily heroin users. And when you use heroin as your main drug, you might have to use, maybe, depending on the purity of the drug, you might have to use 8-10 times a day to stave off withdrawal. However, with fentanyl, because the half-life is so short, meaning the length of time it stays in your system, folks have been having to use much more throughout the day and night, sometimes twice as much, sometimes even more, up to 20, sometimes 30 times a day to stave off withdrawal. And so over the course of this past year and a half, we've seen many people who used to be injection users. Now they've simply lost access to finding a vein, to finding a way to safely inject. And so they've had to transition to smoking due to this, smoking their drug, because they simply don't have a means to inject. That flyer down there on the bottom left, I want to thank Public Health Seattle and King County for making that. That shows you a version of the M30 pill that I was discussing earlier. So when you see those, you can most likely assume fentanyl is going to be in there. Another trend that we're seeing is that polysubstance use is rising. Poly just meaning more than one. So folks are taking more than one drug at a time. And this primarily has to do with folks who used to identify as heroin or opioid-only users. Many of these folks are now reporting also using methamphetamine, either before, during, or after when they're using their opioid. And this is of concern for a couple of reasons. One being that, again, we're also seeing fentanyl in the methamphetamine supply. So a person could accidentally take more of an opioid than they intended to if the methamphetamine they're taking also contains fentanyl. Another concern is that methamphetamine works on your body in different ways than an opioid does. And should an overdose occur, your body just might have less energy and effort to be able to fight back against an overdose. People take methamphetamine and opioids, for a number of reasons. They might, be living homeless. They might have to take methamphetamine at night to stay up and awake so they don't get attacked or robbed, or vice versa. They might, take methamphetamine during the day to go out and do their job, and take opioids at night to level off. A good trend that we're seeing, though, is that naloxone here in Washington is now widely available. All of our state Medicaid plans, think Apple Health, reimburse the bystander for the out-of-pocket cost for naloxone at a pharmacy. So anybody out there that has Medicaid can go to any pharmacy here in Washington State and receive a naloxone kit with no out-of-pocket cost. Most all Costco, Safeway, Rite Aid, and Albertsons locations will dispense naloxone without a prescription. Many other chain pharmacies and mom and pop pharmacies do this as well. I just mentioned those 4 businesses because we've been told by their offices that they will do this. Next slide, please. Another good trend that we're seeing is that in 2010, we enacted our Good Samaritan Law. Some of you might be familiar with this law. This law protects individuals against prosecution for possession of personal amounts of drugs should they overdose or should they be at a scene of an overdose and law enforcement shows up and searches them. It also protects minors against possession of alcohol. However, the Good Samaritan Law does have some caveats or asterisks next to it. The main one being that if you have Department of Corrections supervision, think probation, parole, or community custody. If you're at the scene of an overdose, or if you overdose yourself, you might be violated and charged if you have Department of Corrections supervision or an active warrant. Or if there's other factors there, like scales that have been used to weigh out drugs, or unregistered firearms, or in the case of controlled substance homicide. This is a law that we have here in Washington. Other states have it as well. That states if a person were to administer or sell a drug to someone, and the person who buys the drug or takes the drug overdoses and dies, the person who sold or administered the drug can be charged with controlled substance homicide. I came across a case up in Bellingham, I believe, a few weeks back, where this law was where someone was charged with this law. It's not used very often, but we do hear about it from time to time. In 2015, we enacted our state's Naloxone law. This law simply states that anyone in Washington who is either at risk of witnessing or experiencing an overdose can carry and administer naloxone. And in 2019, just a few years back, we enacted our statewide standing order to dispense naloxone. The statewide standing order does two primary things. One is that it acts as a prescription for someone to receive a naloxone kit from a pharmacy if they do not have access to a primary care provider who's willing to write one for them. So, and you can find the statewide standing order online. Just Google Washington State statewide standing order. It'll take you right to it. You can take a version of this order to a pharmacy if you do not have a prescription and receive a naloxone kit. Now, the statewide standing order doesn't pay for the kit, so if you don't have insurance or if your insurance doesn't cover the entire cost, you might still have to pay something, but it does act as a prescription though. The other thing it does is that it allows agencies or businesses that do not have a medical provider on site to write them a prescription for naloxone. It allows them to receive and distribute naloxone to the community. So, a lot of organizations that work with people who use drugs, a lot of them don't have a medical provider on their staff. I think a lot of housing agencies and other social service agencies. Well, the statewide standing order allows them to receive and distribute naloxone, and it's really helped increase access, across the state. Next slide, please. So we're going to wrap up with these next two slides, and this is meant to show you how we got to this point in time as far as drug use and overdose. I want you all to think back to around 1996. Okay, something happened. Pain began to be recognized as a vital sign. Think when you go to the hospital or to the emergency room and the doctor asks you, or the nurse asks you, on a scale of 1 to 10, how's your pain? Or they show you that piece of paper with all the smiley and sad faces, and they ask you to point to the face, which one best represents you. They didn't always do that. That came about, in the mid-90s. It was pushed for, my understanding is that it was pushed for and advocated for by the Veterans Administration and also by the pharmaceutical industry. Well, with this new recognition of pain came new medications, primarily OxyContin. Most of you have heard about OxyContin before. OxyContin was marketed as a quote-unquote non-addictive opioid. because it had a time and has a time release coating on it. So the idea was that you would take this pill and the coating would allow the medication to be released into your system over the course of hours, rather than feeling all of the effects immediately. And the thinking was, since it had this time release coating on it, you couldn't become, quote unquote, addicted to it, or you wouldn't develop that physical need that I talked about earlier. Well, that's simply not the case, okay? If you take an opioid, it doesn't matter if it has a time release coating on it, or if it's wrapped in a burrito or smeared on bread, you're going to develop a physical need, all right? And people early on figured out ways to remove that coating so they could take the Oxycontin and feel all the effects immediately. They figured out ways to liquefy it and inject it. They learned how to smoke it. And many people who are not the initial persons being prescribed the medication wind up using them recreationally. With this influx of new pain medication came new ways to obtain them. Around the late 90s, early 2000s, we saw a proliferation of online pharmacies. These were ways someone could go online and simply type in their credit card number and never had to see a physician. They would just report having pain, having knee pain or back pain, and they would receive the medication in the mail. The federal government caught on to these fairly quickly and shut them down. And as they went away in early 2000, mid 2000, we saw a proliferation of what were called pain management clinics, or pill mills, as they were referred to down south. These were just, brick and mortar businesses where you could go in and you might see a doctor, you might not, but if you had cash or if you could pay, you could most likely walk out of there with some form of opioid-based pain medication. Again, the FDA and the DEA caught onto these fairly quickly and shut them, pretty much all of them, down around 2006, 2007 or so. Now, that's been about 10 years worth of prescribing opioids, created a whole new group of folks who now had that physical need for the opioid medication, but they had no place to go. And so what did they do? Well, many of them turned to the most readily available form of opioids, and for them that was heroin. So if you follow that blue line at the beginning of this chart here, you can see the blue line represents prescription opioid overdoses. Blue line, early 2000s, mid 2000s, late 2000s, kind of peaks around 2007 or 8 or so. The gray line represents heroin overdoses. That stays relatively flatlined until around 2009, 2010. And then we see a near identical decrease in prescription opioid overdose deaths, along with an increase in heroin overdose deaths. Next slide, please. Until we get to the point where we're at now, where in 2020 in Washington, we saw a 37% increase in overdose deaths. This is driven largely due to fentanyl being sold on the street. To give you an idea, what King County alone has been seeing, in 2018, King County reported 66 overdose deaths that were related to fentanyl. In 2019, they reported 113 overdose deaths related to fentanyl. So it doubled. Exact totals, but at last count, they had reported 177 overdose deaths related to fentanyl. And we don't expect this to change for a number of reasons. Probably the biggest one being is that fentanyl is a synthetic opioid, meaning we don't need poppies anymore. We don't need Southeast Asia. We don't need Afghanistan. If you have the chemicals and a place to make it and the knowledge on how to make it, think about how many packs of sugar do you need to give enough fentanyl to your neighborhood or to your city, right? Yeah, so this is where we're at in the game right now. We encourage everyone to carry naloxone, okay? Especially if you're an active drug user. Does not matter what drug you're using. If you are an active drug user, if you're buying your drugs on the street, or if you're getting your drugs anywhere other than a cannabis dispensary or a pharmacy, please carry naloxone. And if you're getting opioid-based pain medications from a pharmacy, it's also a really good idea to carry naloxone. And you might not need it for yourself. You might need it for a friend or a loved one. You can go to a pharmacy and obtain a kit. The pharmacist should not ask you why you're asking for a kit, okay? You can also go to any Syringe Service Program in Washington State and receive a naloxone kit for free, and also training if it's needed on how to use it and administer it. And you can go back to those Syringe Service Programs as often as you need to obtain a naloxone kit. They won't ask you who it's for, so if you have a friend or a loved one who needs a kit, or if you just want to keep one for yourself for when they come over and visit, just in case something happens, please do so, okay? I'm going to end it here. Thanks, Megan, for managing the slides. I apologize again for the technical glitch early on. Thanks again for Kimberly and Mitch for helping us out today, and we are happy to answer any questions that the group might have.
Great. Thank you so much, Sean. That was a very thorough presentation, especially with the history and trends that we are seeing today. We've only had one question so far, and that was on how to get Narcan, which I think you have all answered a few times. I will share another couple links in the chat box or in the comment box as well. You can always go to stopoverdose.org to find naloxone near you. If you're located in King County, you can also go to Laced and Lethal. That website will link you to a page at Kelly Ross Pharmacy where they will mail you naloxone for free. I don't know if anyone else has any additional resources to add there.
Yeah, just want to second what Sean was saying. Have naloxone. It's pretty easy to get. If you do have trouble, I've heard anecdotes and I've experienced some difficulty with going to pharmacies. Like they might not have it in stock, and you might have to wait for it, or just like some pharmacists don't feel comfortable giving it out and you have to wait for the head pharmacist to be there. Just some strange things. So I guess my recommendation would be to be persistent. As Sean said, the standing order does exist. You have, a right to get naloxone from a pharmacy. But if you do have trouble, just don't forget that there are syringe service programs and harm reduction agencies that you can get it from for free. So, and you can always, reach out to Hepatitis Education Project or Washington State Department of Health if you're having difficulty getting it, and we can help you out. So, yeah.
And thanks, Kimberly. Really good point. Seconding that, I just put my email, Megan, in our chat box. If you would, please share it with the group chat. If you do run into any of these issues, excuse me, at your local pharmacy that Kimberly described, please send me an email. And I'm happy to reach out to the pharmacist and let them know what's going on regarding the statewide standing order regarding naloxone regulations here in Washington. I've had to do that a handful of times already. Those pharmacists are happy to learn what's going on and aren't resentful about receiving this phone call. And just like to reiterate as well, syringe service programs are more often than not going to be your easiest avenue to obtain a naloxone kit because it's free and it doesn't take very long. You don't have to you don't have to show ID. have to let them know who you are. Yeah, it's a really good way to obtain one.
One other comment that just came into my mind, it could be a little bit harder. So if you have a preference for nasal Narcan versus the intramuscular naloxone, like maybe you're just not really comfortable with having to draw up the syringe, or not really comfortable around needles, or just find the nasal Narcan easier to use, that can also be easier to potentially get at a harm reduction agency. The nasal Narcan is a lot more expensive. So if you do get that from a pharmacy and you have, private insurance or whatever, you could be responsible for still a significant amount of money. So it sort of depends on your preference as well. If you want the nasal, then also, reach out to your local harm reduction agencies. Does that sound right, Sean?
Yeah, thanks, Kimberly. Yeah, most syringe service programs do keep a small supply of nasal kits on hand when they do have someone who comes and shows up and, admits to not being, comfortable with, syringes or having to inject someone. I can't speak for all the SSPs across the state, what their supply currently is. But again, if you go to a pharmacy, most likely the pharmacy will provide you with an Narcan kit, which is the kit that Kimberly demonstrated earlier, the nasal spray. But all naloxone is good naloxone, okay? And regarding expired naloxone, I just want to touch on this briefly. Some of you might be in possession of an expired naloxone kit. Hold on to that kit, okay? Now this is Sean Hemmerly speaking, not Sean Hemmerly, Department of Health. As a DOH employee, I can't advocate for you to possess or administer expired medication. However, studies have shown that naloxone, if it's been stored properly, meaning kept out of the sunlight and kept at room temperature, has been viable, meaning usable, for up to 30 years. That's 30 years post-expiration. Okay, so if you happen to have an expired naloxone kit that has been stored properly throughout its life, please hold on to it. Mark it use last or use second. Go out and get yourself a new kit, one that's within its expiration time frame, but hold on to that expired one. There's a chance you might need it. Some people have been reporting having to administer more than 2 doses at a time during an overdose event, and each kit only comes with 2 doses. So if for some reason you did not call 911 and you administer both doses that you have and you're out, yeah. So hold on to that expired one. There's a chance you might need it.
Great advice. Thank you, Sean. We only have a couple minutes left and I'm not seeing any additional questions. So I'm going to ask you all a question that we have been asking all of our panelists throughout the series. Can you share with us what gives you hope in the work that you do?
I can go first. I think in this realm of work, a lot of these actions that agencies take and nonprofits take can kind of feel like a Sisyphean task of just over and over and over. There's never going to be enough Narcan. There's never going to be enough clean syringes. But what's been making me hopeful is that mutual aid organizations, especially at HEP, have been coming through a lot more. People who can really reach folks that we can't. So we have mutual aid groups that are in regular contact with populations that we can't reach, like at night, going into houses that we cannot go into to distribute Narcan. So it's really cool to see a community effort of people who currently inject drugs and use, as well as people who don't, come together and make sure that we can get as much Narcan and Naloxone and fresh supplies as many as we possibly can.
Thanks for sharing that, Mitch. Kimberly or Sean, do you want to
go? Just briefly, I would say organizations like Hepatitis Education Project, and others like them that distribute kits to folks in need. As a state agency, I mean, we can buy all the naloxone in the world, but if we don't have organizations like HEP and others, People's Harm Reduction Alliance is another one, to get the naloxone out to the folks who need it, then doesn't do much good. So having organizations like this that are out there day and night working with folks who need it, it really helps us.
Thank you, Sean. All right, Kimberly, round us out.
Yeah, I really want to second what Mitch was saying about mutual aid groups. I think they're doing amazing work out there. I think too, just in it being International Overdose Awareness Day, that it's touched the lives of so many people, and I think that more and more harm reduction is a conversation that is happening among people whose lives it's touched, including like family and loved ones of people who might use opioids. And I think that's just so important in reducing stigma that people who use drugs face, and having these harm reduction conversations and telling more and more people about harm reduction principles gives me a lot of hope. And I hope that more people who use drugs are met with love and understanding and non-judgment, and that the more people that learn about harm reduction, the more people that will be met with that love and understanding. So that's also what gives me hope, in addition to what Sean and Mitch said.
Thank you, Kimberly. I think that was the perfect end of the session. Well, thank you, all three of you today for joining us and for sharing some of your time with us. I know you all are very, very busy. We really appreciate you joining in on the series. And for folks who are watching, please, you are welcome to still continue to post comments, and I will be sure that we at the Washington Poison Center respond to you. Otherwise, I hope to see you at some of the remainder of our sessions throughout the series. I will post a link to where you can access that lineup. And thank you again to Sean, Mitch, and Kimberly.
Thank you, Megan. Bye.
Bye, everyone.
Bye.